like to thank organizers for inviting me and for giving me a chance to talk on the activities of the Japanese Myeloma Society. And this first slide showed a shift in the membership of the Japanese Society of Myeloma, which was established in 1976 by around 30 hematologists who are interested in myeloma. The membership keeps increasing, particularly after the 14th International Myeloma Workshop held in Kyoto, as you remember, in Japan in 2013. And now the membership is approaching to 500 members. Also in this slide, as shown are the name and time of the approval of the currently available novel key drugs for the treatment of multiple myeloma. The bortezomib was the first novel agent approved for relapse disease in 2006, and followed by thalidomide in 2008, and then lenalidomide in 2010. And last year, in 2015, pomalidomide and the panovinostat was also approved for the relapse disease. And we have only two novel agents, bortezomib in 2011 and lenalidomide in 2015, and approved for the untreated myeloma patient. Okay, today I would like to show you the results of a recent retrospective analysis of the patient, about 3,000 patients collected from affiliated hospitals where they are diagnosed and treated in the period between 2001 and 2012. And the results was also compared with the previous data obtained from another 800 patients diagnosed and treated in also from affiliated hospital in the period between 1990 to 2000. Okay, this slide shows the survival curves of a Japanese myeloma patient shown on, shown on your left. And the American patient from Mayo Clinic, shown on your right, diagnosed and treated in two different time periods. So there is a significant improvement in survival in the recent cohort in both countries. And then this slide shows survival curves of the Japanese patient according to different age groups in the period from 1990 to 2000, and in the more recent period from 2001 to 2012. In the earlier time cohort, there was no significant difference in survival between the different age groups. However, in the recent cohort, there is a significant improvement in OS in each age group. This slide shows the OS curves of the different age group according to the two different more recent time period. These two different time periods. From 2001 to 2005 and from 2006 to 2012. Upper figures show the OS curves of the Japanese patients, and the lower figures show the OS curves of the treated at the Mayo Clinic in USA. Although there was no difference in OS of the patient 65 years and younger in the comparison of the two different time periods in US patients, there was a significant improvement in OS in Japanese patients younger than 65 years old. In the period from 2001 to 2005, when high-dose therapy with autologous stem cell transplantation has become standard of care for patients younger than 65 years of age in Japan. Regarding American patients older than 65 years, there's a significant improvement of survival in the recent cohort indicative of the impact of novel agent. Yes. Regarding Japanese patients in the period between 2006 and 2012, when at least 3 giant novel agents were available, median OS of the age group younger than 75 years is significantly extended. However, survival of the patient of 75 years and older in the recent time period from 2006 to 2012 remains poor even in the era of novel agents. This evidence may reflect truly poor survival of frail patients of older than 75 years of age. These two figures show OS of a Japanese patient according to best response to the different time periods. OS of each response category in the recent cohort looks extended when compared with those in the previous cohort. And it is surprising to see the survival curve for each patient achieving stringent CR reach the plateau of 30 months after the start of initial therapy and now is being sustained. And this shows the OS of the patient treated with at least one novel agent is significantly extended than that of the other patient who received non-novel agent therapy both in Japan and America. This slide shows the OS of a Japanese patient according to the ISS stage in different time periods. In the original analysis, the survival curve for stage 2 patient started overlapping with that for stage 3 patients at 17 months after the treatment start. However, when such analysis was performed on larger number, more than 3,000 patients, in the recent time period, the survival curves became clearly separated. Recently, Dr. Palumbo published a revised ISS model whose criteria are shown in this slide. Revised ISS is composed of original ISS plus normal LDH and non-poor cytogenetics. And ISS stage 3 is this original stage 3 and either having high level of LDH or poor cytogenetics. And this slide shows survival curves of the same recent cohort of patients divided according to the original ISS stage on your left and to the revised ISS stages on your right. The separation of the survival curves of the different stages of the revised ISS looks more distinct. Revised ISS stage 1 is considered to capture more favorable patients, and stage 3 more unfavorable patients. The recently method that assesses a response deeper than CR drew attention, and new method to assess MRD have been the hot topics, even in Japan. And in Japan, new methods such as next generation flow, next generation sequencing, and it's not shown, but heavy light assay are currently targets of vigorous investigation. The EuroFlow consortium, in collaboration with the International Myeloma Foundation, IMF, under the IMF's Black Swan Research Initiative, has introduced a new multi-parameter flow cytometry method, which is accurate, highly sensitive, and above all, by using software package, readout is automated and is independent of expert interpretation. EuroFlow NGF is now becoming a global standard for MRD detection. However, the cost of the antibodies used in the EuroFlow method is relatively expensive and might cause an obstacle to a spread in Japan as a routine laboratory test under the Japanese welfare insurance system. So the Japanese Society of Myeloma has started a study to validate inexpensive flow method using other inexpensive antibodies by that head-to-head comparison with the EuroFlow method in collaboration with the IMF. And there's the NGS. The Japanese Society of Myeloma will also start a study to compare NGS with NGF in the MRD assessment in myeloma patients. We will apply targeted exome sequencing to bone marrow samples, and once myeloma-specific genome alteration have been identified, PCR assay will be used to detect peripheral blood mononuclear cells and free plasma DNA harboring the same alterations. Intraclonal heterogeneity combined with the selective growth advantage is considered as an essential prerequisite for disease progression and relapse after treatment. This slide shows demonstrate the existence of two subclones in a patient with IgG kappa myeloma. The one producing intact immunoglobulin, the green color, the yellow color, intact immunoglobulin, and the other producing kappa light chain alone, the red color. And to evaluate the presence of a heterogeneous subset in a myeloma clone, heavy light assay along with relight chain assay could give us an important information. The discrepancy between the IgA heavy light ratio and the kappa free light chain concentration in this slide could indicate the presence of both light chain only producing subset and intact immunoglobulin producing subset. And the heavy light assay may be a method to assess MLD by evaluating resumption of pair suppression, which may be an indicator of a normalization of the immune system, indirectly suggesting an eradication of the tumor clone and lack of its negative impact on the immune system. The Japanese Society of Myeloma holds almost 500 physicians who have a keen interest in myeloma, and as an immediate past president of the society, I don't want them just copy me. Oops. This is a very important part. Not just copy me, but I want them to evolve heterogeneously in a Darwinian branching fashion. Thank you for attention.